All right, so let's talk about glucometers real quick. We're going to go down hyperglycemia road for just a second. So I got to bring y'all into the world. Is there any chance y'all ever going to make a diabetic? Yeah, man, probably about every day. Does anybody personally know a diabetic? All right, so most people even personally know a diabetic. We work with one. He's not here at this campus this semester, but he's got the insulin reader on his arm, always constantly having to monitor that. His phone, we've come a long ways, right? So 20 years ago, they didn't have phone apps and stuff. They could just tell you immediately what your sugar was. What do they have to do? Get out, poke their finger, draw it up. But unfortunately for you guys, y'all don't have a magic wand. So you will have to go back to sticking the patient to be able to check their blood sugar. So we're going to go down that, make sure you understand what all we need to do, how to do it, etc. So who can tell me, how many types of glucometers are there out there? Exactly, I don't know, thousands, right? Thousands. Nobody knows. So what's important? I'm going to go over this one, but what's important for you? Know what your company carries. Know how to work. I can't even say that enough. Know how to work the one that is at your station or hospital or wherever you go to work at. Make sure you understand and know how to use their glucometers, because there's so many varieties it's impossible to even start to go over them. There's basic parts of it that we will talk about. What's the number one thing that most glucometers must have to work? Batteries. So when you come in the morning, it's a good idea. One, check and see if you have batteries in there. I have literally picked up a glucometer, it won't come on, look in the back, batteries are gone. So what that meant was A shift, we're just going to talk about it, let's just call them out. Michael, we're just going to call them out. A shift done come in, had intentions on switching. Are you A shift? You C shift, okay, so good. Nobody going to get their feelings hurt. You're going to have the intentions of putting some new batteries in, they get to the station, and now ADD done kicked in, and somebody already had dinner ready, and they done forgot to go back out there and put batteries in. My point is, as soon as you come in, check. Get your glucometer out, pull it out. Anything that's got a battery, check. Make sure the batteries are in it, working, everything else. So once you see the batteries in it, turn it on. Most of them will come up. These batteries are dead. Most of them will come and have a little bit of readout right here. Now, this goes back to every glucometer is different. Every glucometer is different. Some, when you get a new box of strips, you have to calibrate. Has anyone seen how to calibrate the strips? Okay, so again, this is not all of them. This is some of them. Some of them you'll have strips. You got to put the strip. There'll be a sample strip. You got to put the sample strip in. There'll be a serum. Drip your serum. Do it. It calibrates to the test strips. That's just some of them. Not all of them are like that. So know what yours is like. But most all of them do operate this way. Once you put the strip in, it starts to go through its cycle, and then you only have a few seconds to get your sample. And if you don't do it within a few seconds, what will it read? Let's say you put it in, you set it down, you do your stuff, you get your sample, and it's sat there for like 10, 15 seconds. What will it read? It will read error. You got to put the strip in just before you're ready. So you're going to have your strip set next to it, do all the stuff that I'm about to tell you to do. Then when you're ready, put it in, let it calibrate itself, immediately get your sample, and in a few seconds, you will have your reading. It's pretty straightforward, most of these. You have one side that goes into the glucometer. The other side receives the sample of blood. When you put that in, it calibrates this little white strip in the center, which is pretty typical for most of them. All you need is a drop of blood. You just touch the side of it, the side of the blood, and you will see it draw it in. It's just like it has a straw in there, and there's a magic little person just drawing it in with the straw. You'll see it suck into that. Once that happens, then it's going to start reading your blood sample. A few things to go through whenever you go to stick. There are a variety of lancets. Some of the old school lancets have this thing, you peel off the tip, it's got a little needle on the end. They have these types of guns. Some of them have guns. You put the lancet in, you dial it to the gauge you want, stick it over the finger, you pop it. Personally, my favorite are the little thumb poppers. I don't know if we have any here or not. Have you seen any of the thumb poppers around here, Travis? I haven't seen any. The thumb poppers are good because once you put it in the place you're going to do and you press the center of it, it pops. The needle retracts back in, and then you can squeeze it all you want, and the needle's not going to come back out the end. So it's a permanent retraction. Now, it doesn't matter if you're using that or you're using one of these. What do you do with that needle once you've used it? Immediately, it's got to go in a sharps container. You don't want to just set that down on a desk, and I'll tell you about my personal experience in a minute. So you want to make sure that immediately goes into a sharps container. How you prep the site. Now look, here's what I'm going to tell you. When you go to get your sample, most diabetics have a preference of where they get stuck, what finger, all of it. It's okay. Ask them. Say, hey, do you have a preference on where I get my sample? They'll tell you. If they don't care, what I do is I'll pick a little bit of the side to the center of the finger. It's going to still be sensitive. It's going to be tender. But what you want to do is make sure that there's not a big callus. I have seriously stuck some folks before, and their fingers are so calloused, it didn't make it to the capillary bed. So it just popped, and then there's nothing because it's that thick of a callus. So you want to pick a spot where you can get into the capillaries. When you go to clean it, you take your alcohol swab. We're going to just use my thumb right now, just a demonstration. We're going to clean it really good with an alcohol swab. Then you want to take a 2x2, sterile 2x2, sterile, and dry it off or let it dry. Why do you want to make sure the alcohol is dry before you puncture the skin? Why? Because alcohol residue will give you a false reading. So you want to make sure that alcohol is dry and off the finger. So it's good practice to wipe it. Here's another good practice. So let's say you've cleaned it with alcohol, dried it with your 2x4, 2x2, whatever you got. Now you milk up 1 droplet of blood for your first sample. Take that sterile 2x2, wipe that first one away, then milk it, get a second drop. That's the one you get your sample with. So if I were doing this, I would clean the finger, take the 2x2, dried it off, milked up first drop. I've got this sitting here, so now that first drop of blood's there. Set it in, it's calibrated. You get it, or if you've done a second one, cleaned it, you wiped it off, then you put it in, then you milk up your second one, you get your sample. The idea though is that you put this in at the very last second. You wait till the very last second to put it in. To talk about the difference between IV stick versus the lancet stick. You guys in the field are going to see a whole lot of your paramedics start an IV. Now it depends on the catheters. It's not as easy with some catheters as it used to be. And they would take their 4x4 or something piece of paper, and they're going to squeeze out a little drop of the blood on that, and they're going to throw the sharps in the needle. They're going to get this, and they're going to get the blood over here. And then they're going to tell you, I don't like to stick my patient twice. Let me ask you something. If you I don't care if you've seen it or not, you will see it if you haven't seen it. Why do you think it's more important to get the capillary blood versus the venous blood? Because this is venous blood running through here. On the tips of your fingers is capillary blood. I want you to think about that. What's the difference? You guys going back to Aemt class. This might drain the rest of your power, so some of you are going to immediately fall asleep. That's normal. So just work through that. What is the difference between venous blood and capillary blood?
Different readings.
Okay, so that is the idea, is that it's going to give you a different reading. But why would it give you a different reading? Well, right now, if you were closer and we didn't have COVID going on, I'd give you a chest bump, dog. Yes, 100%. Because of gas exchange. Capillaries is the smallest breakdown of your vascular system. So that's where gas exchange happens. Veins and arteries are like the highways and interstates. Blood's flowing through, you got a lot of other garbage in there. Capillaries is the smallest breakdown. That's where your most accurate blood sugar reading, high or low, on a patient will be, is because of capillaries. You are not going to hear too many people tell you that. They don't talk about that. They don't explain that. The drop of blood's a drop of blood to a lot of folks. Now I'll tell you this, because I'm the who, why, where case study guy, when I was out in the field, I wanted to see how big of a difference was there. So I would start an IV on a person, I'd save that sample, get a drop of it, then I would do a capillary stick, do a drop of it. You know what, on your average Joe, are you a diabetic? Do you mind me asking? Is that personal?
No.
So Terry, are you a diabetic?
No.
You're not a diabetic. Chances are if I checked your blood sugar right now, vein versus capillary, pretty normal. Because your body functions normal, because you're not a diabetic. Take a person that is a diabetic, whose blood sugar swings up and down a lot, because they call them brittle diabetics. you do their venous puncture versus their capillary, chances are you're going to see a big swing. Can 10 to 15 millimeters, deciliters is actually how it's measured, can 10 to 15 deciliters make a difference? What's the difference of 15 deciliters? Let's say that it's they have a 75 on a venous stick. What's 15 off of that? 60, right? So now you're on that borderline of, do I need to give D50 or what? Do I need to start into treatment? Because what's considered normal? Depending on the book you read, 80 to 120, some do say 60 to 120. Some do say 60 to 120, some, and then yours may say 80 to 120. But regardless, if you're at 60, the patient's exhibiting signs of low blood sugar, what should you do? You should treat them. You should treat that. But if it says 80 and they're showing signs of being in and out of it, then what are you starting to think? Now you're thinking maybe this is stroke, or maybe they're intoxicated. All of a sudden the idea that this is a diabetic problem starts to leave you and you start thinking a different direction. That's what I'm getting at. Diabetic patients, it can make a big difference. So you want to make sure that you're doing things the right way, because that's going to dictate the way you treat the patient and what direction you go in. Because guess what mimics hypoglycemia? Intoxicated patients, stroke patients. I had a patient one time, their only complaint was they couldn't see. They were awake, they were alert, they could answer questions, but they woke up and they could not see. They were completely blind. Their blood sugar was in the 60s. I gave them some Coke or something, what I remember, and within 10 minutes they could see again. What's causing that? I'm dropping a lot of knowledge on you guys. Right now, everybody's like, are you serious? I didn't pay for all this. No, you probably didn't. It's okay, it's extra. I'm not going to charge you. So what is doing that? What's causing a person to suddenly lose their eyesight? Or maybe they slur their speech. Or maybe they just break out in a hard, cold sweat. It's all about the area of your brain that is being depleted of the sugar. Your brain's a very complex system. I don't know if any of you guys have ever went on YouTube seen like brain surgery. They do brain mapping. You ever heard of brain mapping? So they have a section of your skull out. You're awake on the table. They're talking to you, and they're touching pieces of your brain. And they're like, ask you a question. And when they hit your speech center, the person will be like, yeah, I feel good. And they pull it off, and then all of a sudden they're normal again. I'm not joking on that. That's legit. Look it up right now. You're like, Tay's like, this is bullcrap. No, I'm serious. Your brain is that sensitive. Areas of your brain control different parts of what your body does. So depending on what part of your brain is lacking the sugar, will give different symptoms. There's just common signs and symptoms you look for on hypo or hyperglycemia. This glucometer is a diagnostic tool. So it gives you kind of more of a window to what to think and what to treat. So knowing history is important. So you're going to find out what kind of history they have. This is important to check. Now, who should you check a blood sugar on? Just if they say they're diabetic? Altered mental status, key, huge, massive altered mental status. Altered mental status. Anybody with altered mental status. Even if they say, yeah, we know he's a drug user, and they're altered mental status. Should you check a blood sugar? Yes. Guess who else you should check a blood sugar on each and every single time? Wide awake talking to you, doesn't matter.
If they are diabetic?
Well, if they are diabetic, 100%. Pregnancy. Anybody that is pregnant, doesn't matter what trimester they're in. Why is that? Has anyone ever heard of gestational diabetes? So people that are perfectly normal, have no history of it, get pregnant, suddenly they develop diabetes. So you need to check a blood sugar on all of your OB patients, every single OB patient, every single time. They may be in their third trimester. They may have never been told they have gestational diabetes. But all of a sudden, the third trimester, hormones are changing. Now they've got it. So always check, crossing those boxes off. Okay, good. So we have a pretty good idea of why we're going to use a glucometer. We have a pretty good idea of how to use the glucometer. We understand why capillaries can be more important than venous, especially on those patients that are of the demographic of diabetics. Now what we need to do is, what the crap did we do for these people that have high and low blood sugar? So if you have somebody with really high blood sugar, what do you do? We're going to go high. 250. It's real simple. For you guys, therapeutic care, supportive care. Make sure they have a patent airway. Start a line on them, start a bag of fluid, get them to the hospital. What do they need? What's definitive care? Anybody know what definitive care for somebody with high blood sugar? Something paramedics can't even give. Insulin. Insulin is going to be the key for these guys. You don't carry that. So the key is to get them to a hospital quickly. So how high, or what is the range for most glucometers? Man, I'm dropping so much knowledge. I hope you guys are retaining this. I hope you have like a back wallet somewhere, a motherboard, just like downloading it constantly. Terrio, is that working out for you? Okay. So what do you think, Ariel? What you got? What's the high low on your on most of these right here in the field? There's a range. Anything below 25 would read what? Just says low. I'm just seeing how much anybody's seen or knows. It's just going to have LO, low. Ain't even throwing a W in there. It's just too low to be low. So anything below 25, low. Anything over 500, what's it going to say? High. And it's HI, like hello. It didn't even throw a GH in there. So it's grammatically incorrect, just not enough room on the screen is what I'm assuming. So it's going to say high. So if it's over 500, it's going to say high. Below 25, it's going to say low. High could be anything. The only way they're going to know is when they get to the hospital, they're going to do labs. The highest I've seen is somewhere in the range 1500 in hospital labs. It's outrageous. Guess what happens whenever you start to get that high of a blood sugar? Organ failure. It starts to damage your kidneys. Everything is really heavily affected. So time is of the essence. What I'm getting at is diabetics, you're going to make a lot of them. You're going to have your regulars. You're going to make the ones that they forget to take their shot. You're going to make those that take their shot forget to eat. They go to bed, they go to sleep, you come in the morning, and you're getting a call at 7:15, and you get there, and it's Mr. Smith that you've made 50 times because he's forgetful, and he's taking his shot the night before he forgot to eat and he went to bed. Happens all the time. But what I'm trying to impress upon you guys is to not take it for granted. Don't let it be like, oh, no big deal. When you get your blood sugar, and you make sure this goes to the sharps, I'm going to tell you my quick story. If you have these independent lancets, you never ever want to just set it down next to your other stuff. You want to make sure it goes straight to a sharps container. When I was a brand new medic, stuck a guy, set it down. Now one good thing about this is these needles are solid, they're not hollow needles, which means it doesn't carry blood in the center. I set it down, we were doing stuff, he started going downhill. We started getting our stuff together real quick. I picked up a ball of garbage, needle was in it, stuck me. I got news for you. Dirty needle sticks will scare you to death because now you don't know what you got. Patient ended up having hepatitis C. So even more concern, right? Because guess who else I'm trying to protect besides me? My family at home. So I don't want to have to bring something home to them. 6 months of tests later, I was good, thankfully. But it could have ended differently. So protect yourself, always pay attention to your sharps. Make sure those things go straight to a sharps container. I'll point that out because obviously I tried to be on my game and I made the mistake, so it can happen to absolutely anybody. Now, let's say your patient's blood sugar is, it doesn't matter if it's 50, 40. My wife works with a lady who has a horrible time trying to control her blood sugar all the time. The other day she's at work and she's like, ooh, I'm feeling shaky and weak. I'm getting dizzy. Checked her blood sugar was in her 30s. She just went and got Coke, started drinking it. So you're at the house, patient has low blood sugar. They're wide awake, they're talking to you. What can you do for them? If you're at the house, you may offer some orange juice or Coke, something like that. If you're out there in the field, you need to use this oral glucose. All right, so I'm going to tell you how the book tells you to give it. I'm going to tell you how you can also give it. So the book tells you to get a tongue depressor. You can take the tube, pop it open, squirt it on the tube, or squirt the tube on the tongue depressor, put it in the cheek, wipe it off, let them swallow that. What's this area called? Giving you the medical terms. What is this called where you're putting the glucose? Give it to me. Buccal. Buccal. Y'all never heard buccal? Yeah. Man, have I dropped so much knowledge now y'all almost passed out. Who got Miss Trigg? Oh, I'm telling Miss Trigg. I know she said buccal once or twice. So buccal. How I usually did this, because this stuff doesn't always taste great, but they have different flavors now. Twist it, and if the patient's wide awake and that, it's good to see how awake they are. You let them squirt it into their cheek. Just tell them squirt right into the side of your cheek, kind of let it dissolve some. Once it starts to dissolve, you need to swallow. You can swallow. You want them to try to let it absorb as much as possible before they swallow. How much of this do you give them? The whole tube. And then afterwards, give it a few minutes, check a blood sugar again. The whole tube. Give you the measurement on this. It's 37.5 grams. 37.5 grams is what one tube of glucose is. All right, so what is so important about this before you give it to them? Obviously, their blood sugar's low. They got to be able to swallow. They got to be able to swallow their own saliva. If you give this to somebody and they're in and out of consciousness, I mean, like some of you right now, some of you are in and out of consciousness. If I pick the right moment and start squirting this in your mouth, what might happen to you? You might choke to death. Now you've caused a whole other problem. So you gotta make sure they're awake enough to be able to control that, hold it in their mouth, and then be able to swallow it. I don't know if any of you guys have seen Seinfeld ever. My favorite. If we had a video, I'd just immediately point to it. This is like my dream classroom. Be like, don't do this. There was a moment where Elaine was dating this old guy and he passed out. And so like they're shoving cookies in his mouth. And they're like trying to get him to chew it up. And the EMTs get there and like, why are there cookies in his mouth? You wouldn't do that to a person that's passed out. All right, good. So glucose can be your friend. Somebody that's awake. Get the sugar up. You want to go least invasive, most invasive. Now, obviously, this patient is passed out. Cannot get them to wake up. You cannot get them to be able to swallow anything. You need other options. You guys are blessed. I say you're blessed because I didn't have this option whenever I was y'all's time out in the field like you are now. For me, we only had either get an IV or haul butt. They have glucagon now. Glucagon, you can give this, how? You can't give it intravenous, but if you can get it intravenous, you're going to be given D50. So this is if you can't get a line, you can go IM. So if you can't get an IV, this can actually be given IM. What does IM mean? Intramuscular, right? This is sterile water. This is 1 milliliter of sterile water. And this is 1 milligram of the medicine. You notice this is a powder. Obviously sterile water, it's a liquid. You guys are going to have to, what they call reconstitute. So you get you a syringe. Some of these come with it. In fact, I think I saw in one of y'all's bags, you have a red container. Look in that bag for me if you don't mind. I want to say it was in there. Where your medicines are. Yeah. See that red plastic container there on top? That's glucagon. So sometimes it comes packaged like that. Sometimes it comes in a little box and it has these two little carriers. But you see, you still have to reconstitute it. So even though it's in there, you've got the sterile water. And it is missing. Oh, it's already been used is why. And it's supposed to have a little tube of glucagon in it. Maybe this one has it. Y'all got all kind of stuff up in here. Y'all high rolling. Y'all can save some people's lives, man. Yeah. See how it has, it's got the powder in there. It's got the sterile water already pre-syringed for you. So all you have to do is just shoot that in there, but then you got to draw it back up. I'm going to show you how to do that. So you get your glucagon out. If you're doing it with 2 vials, it's important that you also look cool. Look, I'm going to tell you, Terry, I'm all about some cool points. It's good. You got to do it right. If you don't do it right, well, then all is lost. But doing it right and doing it cool, it matters. So you get it, you got to have your index fingers across it so you got good control. Put your thumbs behind it. Same time. Can you do this at the same time? You got this? Let me see, Terry. Can you do this? All right. What about you, Donna? Can you go like this, opposite? Can you go opposite? Y'all can't. So it's called coordination. Coordination. 2 thumbs same time. I couldn't do it. See? It's important. I lost cool points. Got them both on here. You got to pop them both at the same time. If you pop them, they shoot across the room. Cool, Tay. Take your time. Draw it in. All right, so you got them. Boom. Take your needle. I'm going to show you how to draw up IM stuff in a minute. That's part of this. But you want to get some air in your syringe. Okay? This had a top on it, so that means this rubber stopper was already sterile. Unless you set it down and go do something else. It's sterile as soon as you take it off. So there's no need to clean it. This would have been a multi-dose vial sitting there. You got to clean it. This wasn't. I'm going to show you all about points of contact, control your needle, straight in. Look. Inject the air. That's going to kind of like preload the inside. And then you want to draw up every bit of the fluid in there. Get your air out. And this, where the powder is, again, points of contact. I'll explain all this to you in a minute. Shoot that in. Now you got to shake it up. Then when you look at it, it should be almost clear, just a little cloudy. Now, Draw up all your meds. Get the air out. You're ready to go. So now you're going to give this IM. We're going to go over IM injections in a minute. Deltoid, easiest spot to get. Show you about the cleaning process. 90-degree, draw back, then inject. We're going to go over IM injections. That's just the gist of it. So that's how you give glucagon. Now, why is this not preferred over D50? Because this is obviously easier and quicker to draw up and you don't have to worry about sticking an IV. Why is this preferred? Not preferred, I mean. Because it's slow acting. This is going to take, because it's going into the muscle, it's going to take 15-20 minutes to start to be absorbed. So if you have to give this to a patient because you couldn't get a line, you need to be working towards getting them packaged and going to the hospital. Because if you can't get a line on them, you're going to need that eventually. So this is just something to be able to treat them and be able to start transporting. Any questions on it? That's glucagon. The 6 rights are important in the sense of you want to make sure that it meets what you're looking for the patient, that the patient's blood sugar is low, you can't get an IV. And they need to be treated, but obviously you're giving it, so it's hard to ask about allergies and stuff if the patient's unresponsive. Sometimes you're just going to have to do what you got to do, and that you got to make sure the treatment matches what's going on. No questions on glucagon. All right, so we went over glucometer, glucose, glucagon,